Hello, my name is Emily Bascom, and I'm a fourth-year undergraduate student at the University of Washington Information School. Today, I will be presenting on my abstract toward patient-centered informatics solutions, the role of intersectionality. Before I begin, I have no relevant relationships with commercial interests to disclose. The learning objectives of this session are to understand that quality patient-centered informatics solutions cannot exist without the consideration of intersectionality, to recognize the definition of intersectionality is complex and should be interpreted based on the context in which it is to be applied, to understand how intersectionality plays a role in the interactions marginalized patients have with healthcare providers, and to identify opportunities to promote the inclusion of intersectional participants in research. Before informatics systems can support equitable, diverse, and inclusive healthcare, we need to understand the impact of intersectionality on people's experiences. According to the Merriam-Webster Dictionary, intersectionality is the complex, cumulative way in which the effects of multiple forms of discrimination, such as racism, sexism, and classism, combine, overlap, or intersect, especially in the experiences of marginalized individuals or groups. Thus, experienced oppression is not based on a single axis of identity, but rather on the interwoven aspects of identity. Coined by Kimberly Crenshaw in 1989, the term originally referred to the unique oppression that the intersection of race and gender brought to individuals. Today, the term has expanded to include other identities. For example, ethnicity, gender identity, sexual orientation, religion, body weight, or height. There is a lack of research describing the lived experience of implicit healthcare bias from an intersectionality perspective. Incorporating the concept of intersectionality in the clinical environment, including in clinical information systems, acknowledges the whole person and the complexity of the patient-provider interaction. This helps to dismantle the cis-heteronormative privileges that are present in the healthcare system, which assumes things such as a person's gender identity is their sex assigned at birth, or that they are cisgender, and that they are sexually attracted to people from the opposite gender, meaning that they are heterosexual. These privileges inform providers' implicit biases, which can contribute to unfair medical treatment of patients with historically marginalized intersectional identities, and is perpetuated by health information technology. Here, I will present the intersectional identities that Black, Indigenous, people of color, and/or lesbian, gay, bisexual, transgender, or gender diverse patients shared in their stories related to unfair treatment, elaborate on what we learned from those stories, and discuss the importance of intersectionality for developing solutions to enhance patient-centered care. We are investigating healthcare biases experienced by BIPOC and LGBTQ+ people, and how to improve those experiences in future interactions with their healthcare providers. We were looking to answer the question, how do BIPOC and LGBTQ+ patients experience biases in healthcare? This presentation will focus on how the theme of intersectionality emerged through the analysis of this data. However, my colleague Reggie Casanova-Perez is presenting results on both the experiences of and solutions proposed by our participants. So I highly suggest that you go and listen to his talk, which is session S91, Managing Diversity in Consumer Informatics. To investigate the lived experiences of bias towards race, sexual orientation, and gender identity experienced by patients from marginalized groups, we collected 25 stories from patients who are BIPOC and/or LGBTQ+ through 1-hour semi-structured interviews. We interviewed 25 BIPOC and LGBTQ+ participants, ages ranging from 19 to 60, to investigate how they experience biases in healthcare. 11 participants were BIPOC, 3 were LGBTQ+, and 10 were BIPOC and LGBTQ+. One participant did not report being BIPOC or LGBTQ+, but self-described as being an older Asian woman. As we expected, 17 participants brought up racism, 7 participants shared discrimination based on sexual orientation, and 4 participants shared discrimination based on gender identity throughout the stories that they shared. Although we originally focused on race, gender identity, and sexual orientation, over half of our participants, without probing, shared other types of discrimination. 6 mentioned sexism, or assumptions made based on a person's biological sex. 4 mentioned sizeism, assumptions made based on a person's body weight. 3 mentioned ageism, or assumptions made based on a person's age. 1 mentioned discrimination based on their height, and 1 mentioned discrimination based on legal recreational drug use. We realized that focusing on racism and LGBTQ plus discrimination was myopic, that understanding the whole person requires acknowledging that there are multiple layers to and many types of discrimination that people will encounter in healthcare and when using medical information systems. This brought to our awareness that in healthcare in particular, the impact of many layers and types of discrimination are often left unexamined because they have not yet received the same attention as medical racism, which can result in gaps in traditional training devoted only to implicit race bias in healthcare. Because of this, providers may not recognize or know how to address patients' intersectional identities. As participant 16 commented, just in every way that I am different from my doctor, I think is a barrier. Honestly, the more things we have in common, the more welcomed I have felt. So even if that's just gender sometimes, that is even just a huge difference. This limited understanding doctors can have can leave marginalized patients feeling as though they have been taken advantage of and like they are not receiving the best care possible. For example, participant 11, a Black queer woman, explained, I complained about knee pain all the time and doctors always said, lose weight, lose weight, lose weight. I got injured on a theme park ride, and when the x-rays came back, the doctor was like, you have arthritis in one of your knees and also your kneecap is misaligned. I have been dismissed for a decade. Maybe I wouldn't have arthritis in my knee right now had the doctor listened to me previously when I expressed pain. The complexity of participant 11's identity greatly limited the care she received, demonstrating the opportunity for innovative health informatics solutions that can represent patients in their entirety to support doctors in providing equitable, patient-centered care. These findings provide insight into how the healthcare system fails to adequately and fairly treat the diverse health and wellness needs of patients with intersectional identities. Understanding how intersectional identities play a role in unfair treatment experiences is crucial for ensuring that patients are treated holistically and with fairness in clinical interactions and in clinical information systems. How can we, in the biomedical informatics community, move toward patient-centered informatics solutions that empower patients with intersectional identities and encourage holistic treatment? How do we begin tackling the systemic issues that reinforce the barriers that prevent empowering patients? We must prioritize conversations that work to establish what intersectionality means in our field and how we can make intersectionality an expectation rather than an afterthought in our informatics research and practice. Intersectional identities are under-researched as a whole. For example, current demographic categories that inform patient-centered healthcare methods restrict consideration of patients' identities to dichotomized dimensions: women versus men, Black versus white, young versus old. These binary categories fail to account for individuals with multiple identities that influence the care they may need. The health informatics community should prioritize ways to reinvent our conventional methods of categorizing individuals in our tools, from patient-reported outcomes to electronic health records, and in our research and informatics interventions. Patient-centered informatics solutions can only be successful by considering the entirety of who a person is, as complex as that can be, and not by who they are assumed to be based on their physical characteristics and historic privilege. How can we lift up and elevate the work of intersectional and diverse researchers to overcome the white gaze savior complex found in this work? To overcome this complex, Christina Harrington, Sheena Arrett, and Anne-Marie Piper suggest that, quote, researchers need to acknowledge the unintentional harm that may occur simply by their presence in these research environments. Researchers should look to focus more on the fullness of engagement, supporting community residents to engage on their own terms and share narratives that they deem important. In a comfortable environment may push us closer to design engagements where these individuals feel empowered rather than further marginalized, end quote. This is opposed to making generalized assumptions about groups and about people, which leads to my next recommendation, being we need to understand participants' experiences to inform patient-centered solutions. When truly trying to understand participants' experiences, you will discover problems they face that you had not anticipated. This is truly important when designing ubiquitous technology that is going to be used by many people. And from that, because the technology we create as medical informaticians is touching so many people regarding something as intimate as their personal health and well-being, we need to make sure we're doing our best to design with people of all backgrounds in mind, not just the ones that are most accessible to us as designers or most like us as people. We need to prioritize designing for intersectional people with the goal of diversifying the experiences we are putting into the world. And with that, we want to acknowledge our participants for sharing their experiences, our community champions who helped us recruit, and our advisory board members who helped frame this study. I would also like to thank the Unbiased team at the University of Washington and the University of California, San Diego for the engaging discussion surrounding this topic. Thank you for listening. You can contact me by emailing me at embascom@uw.edu.